I am honored to introduce you to today's speaker, Dr. Monique Gary. Dr. Gary is a board certified, fellowship trained breast surgical oncologist. She is medical director at Grandview Health and Penn Center Cancer Network Program. Dr. Gary does so much for those of us with a breast cancer diagnosis and is a great friend of LBBC. Please read her full bio on lbbc.org.
Hi, good evening. Hello, everybody. Woo! This is, boy, this is a loaded topic, and it's probably a topic that is more than we can discuss today. It's going to get to be more than I think we'll have time for, but I'm going to do my best to, one, give an overview of the sort of genomic landscape, right? And then two, talk about some of the technology that we have and how genomics helps us look at risk of recurrence. But then three, what are some of the evidence-based things that you can do to focus on the things that you can control? Because I'd like to frame this in the context of a really pivotal life event, right? Cancer changes everything. It is the lightning strike in your life that now makes you want to think twice about stepping outside your door because of fear that lightning will strike again. And so I use that in the context, or I use that to say that the fear of recurrence is so much more than the fear of actual in-breast or tumor recurrence, fear of metastatic disease. There's a lot of mental gymnastics and things that happen that influence that fear. And so the second part of this talk that you're going to get, I think next week, is going to be even more pivotal than this one, because it talks about how to deal with that, right? That battlefield of the mind, as it were. So we'll talk about some physical stuff, right? And then we're going to talk a little bit more about some of the ways that we're looking at recurrence. So as they mentioned, I'm Dr. Mo. I'm a breast surgeon. I'm CEO of a farm for integrative wellness in Bucks County. I'm a professor and faculty at Dartmouth. So I wear a lot of hats, but the one that I'm so proud of is to be a breast surgical oncologist. And I get to have the privilege of taking care of breast cancer patients every single day. And it is truly my life's work and my life's mission. And I dedicate this all to my mother, who had ovarian cancer, 29, and my grandmother, who had bilateral cancer that didn't show up on mammograms, called invasive lobular carcinoma. And so the work that I do is an extension of the care that I wish they had received, and that I hope you all are receiving wherever you are in the world. So we're going to talk about understanding risk of recurrence. And the first thing you should know, if you don't already, and you probably do, but just to level set, is that breast cancer is not one single disease. It never was, but it really, really isn't now. And so there's so many tools that help us to refine both the prognosis, assess how treatment is going. And it used to be, we had a T&M scoring system when someone would say, okay, your stage of cancer is this. It's based on the tumor, the node, and then any evidence of metastatic disease. And then we learned about hormone receptors, and we're going to talk a little bit about that. And now there's proliferation scores, there's computer models, there's molecular assays, there's all sorts of really interesting things happening to help us understand how breast cancer is unique and how to make the treatments that much more precise. And this is an ongoing study. So my disclaimer here is that I don't have all the answers. And so there may be a lot of I don't knows, but it's good questions that you can take back to your oncologist. And it's good questions that you can ask LBBC to continue to provide programming around. So when I talk about precision in treatment and this genomic explosion, what do I mean? Right? You might see some of this stuff that looks a little bit familiar, but basically, when we talk about understanding the tumor's biology, we used to just think it was about the estrogen receptor and the progesterone receptor, or the little the stations on top that cancer cell. Now we know, right, that there are different subtypes of breast cancer, and a subtype tells us exactly how it's going to behave. It tells us what it responds to. It doesn't tell us what caused it. We don't know what caused cancer, but it kind of tells us whether or not estrogen is driving it, and whether or not progesterone is driving it, and whether or not it's expressing something called HER2, or this human epidermal growth factor receptor, right? So when these cancer cells have receptors, the simplest explanation I use is it's like having toll booths on the turnpike. If you got a toll booth, I know you're using $1. right? So estrogen's your dollar. And the basis for your whole body treatment is going to be partially blocking that estrogen, taking away your dollar so you don't go through more toll booths. So we used to think it kind of stopped there, right? But there are subtypes of breast cancer. You may hear your oncologist say luminal A, right, which is estrogen receptor, any PR, the HER2 is negative and the proliferation score is low. You might hear your doctor say you have luminal type B, luminal B breast cancers, right? These are a little bit more aggressive, right? When we look at the prognosis from the best prognosis, moving on down to the worst prognosis. And you can see when HER2, that protein is overexpressed, that prognosis getting a little worse, triple negative, right? Your cancer cells don't have any toll booths on them that we know of at this time. Right. And so it's kind of like being in the easy pass lane. I'm in Pennsylvania, so people in PA know easy pass, right? But basically I can't take away your dollars because you're not using dollars. So how do we treat you and how do we manage, the whole body therapy? Because the way you have to think about breast cancer, and I know I'm probably preaching to the choir, is that something treats the breast. That's what the surgery does. That's what the radiation does. And something treats the rest, the whole body. That's what your medical oncologist does. And so we're going to be talking a lot about sort of what the medical oncologist does and how they use these tools to make decisions. But what you should get from this is that there are so many different types of breast cancer based on these receptors and these proliferation rates. And depending on what you have, there's a better or a slightly worse prognosis. And the treatments are kind of tailored to some of these too. Right? And so they become predictive and prognostic. So not just predicting how well you're going to do in treatment, but can we predict or can we say what it's going to do for your prognosis, how long you're going to live and whether or not cancer is going to come back. And these markers kind of are that, right? And so there are markers that help us to figure out how likely cancer is to happen again, whether or not you've got cancer in your lymph nodes and how many lymph nodes, the grade or how fast a tumor is growing, the size of a tumor, age, not as much, although we tend to think young people, more aggressive cancers. This LVI, this word means lymphovascular invasion. Are there tumor cells in the lymphatics or the spider web system surrounding a tumor, right? Think about your tumor like chewing gum in a spider web. The tumor's the chewing gum, but in the spider web or the lymphatics, right? Now you've got a network that can go places. So when you have cancer cells that have invaded those lymphatics or that spider web system around the tumor, we start to think, okay, is this a higher risk of cancer coming back again? Our hormone receptors, right? Our ER, our PR, our HER2 new, and then these genomic assays, right? So genetics is what you're born with. Genomics is what happens in the tumor. And I'll give you the analogy of oh gosh, it's showing my age here, but some of you will be able to relate. Give me a little reaction in the chat if you're able to relate to I Love Lucy, right? In that episode where she and Ethel work in a chocolate factory, right? You know what happens in that episode. The chocolates are coming off the conveyor belt and they're doing pretty good. They're putting the wrappers on them and all of a sudden the belt goes crazy. The machine goes haywire. You got 1, 2, 4 chocolates. She's stuffing them in her pockets, putting them in her cheeks. She's putting them in her hat, right? That's what happens with cancer. 1 makes 2, 2 makes 4, 4 makes a million. There's a change in the machine, right? That happens that makes it happen. But not all those mistakes get passed down generation after generation. That's heredity. Right? So that's genetic. Genomic means what happened in that machine? What happened in that tumor? And what are the changes that we can either use to diagnose, to treat, or to predict risk of recurrence? So we figured out, well, there's some ways to look at the machine. There are some assays, and that word assay means a test. There are some tests. The genomic assays mean tumor tests. There are 3 that we really use. The 4th one, not as much, but the first one you all should have hopefully heard of. Ebony Joy, I'd love to know if you have heard of an Oncotype DX, right? If you've heard of Oncotype, put a check mark in the chat. You might have heard of MammaPrint. You might have heard of MammaStrat, although not too many people are using that one. And Prosigna is also called PAM50. So what do I mean by that? All right, let's start with the Oncotype one. It's the most common. And when you see your doctor, or my patients will ask me when they come for their post-op, doc, what's my Oncotype score? It estimates the risk of recurrence for early stage hormone receptor positive breast cancer. So the ER, the estrogen's positive, the HER2's negative. This is considered a favorable subtype. And I hate that word favorable because nobody's cancer is favorable. But some cancers will behave will behave badly. And so these types of assays are for people whose subtype seems to be favorable, but we want to know, is it truly? If 70% or 75% of people who have this type don't need chemo, who are the 20% that do? Who are the 30% that do? And that's what this test helps us to understand. So it helps us to understand how likely is a person to benefit from chemotherapy, right? It estimates the risk of recurrence for DCIS now, so stage 0, right? We're starting to understand stage 0 is a very different disease. And when I say stage 0, the best way to think about that is think about your milk duct like an empty paper towel roll lined with bubble wrap on the inside. When that bubble wrap duplicates, replicates, and keeps growing, or a can of Pillsbury biscuits, crescent rolls, when the can pops open and the dough pops out, that's invasive cancer. When the dough's rising and it's still stuck in the can, that's DCIS stage 0. And so how likely is that now, right, to happen again, to invade, to break out? How likely is somebody to benefit from radiation? So that's what this test tells us. And it analyzes the activity of 21 genes and it calculates a score. The higher the score, the greater the risk of recurrence. And it's now a tool that we use to help talk about things like chemotherapy and even radiation. So that was a first generation test. That was the one we kind of knew that there were 21 genes we could look at and we could figure out whether or not your risk of cancer happening again somewhere else in the body is so high that you would need chemotherapy. And again, this is for the favorable types of breast cancer, the ER positive ones, because if you've got triple negative, if you've got HER2 positive, those you would know that anything greater than 5 millimeters, any tumor greater than that, you're likely to be recommended chemotherapy. So this is a different conversation for you. Mammoprint. Now we're up to 70 different genes, right? So we can take a tumor sample, we can take some tissue that's removed, we can spin it down and get some RNA and some cDNA, and we can do some comparative gene analysis, and we can branch you out into either high risk or low risk. There's some interesting controversies going on right now between Oncotype and Mammoprint as to whether or not they're most helpful for women of color who tend to have more aggressive cancers, whether or not they're more relevant or more precise. So there's a lot of talk happening in the medical world right now. Some doctors are using Oncotype, most of us are. Some of us are using Mammoprint. Some of us are using both. Right? So this is helping us to decide who needs chemotherapy, and it also helps us to decide how long you need to be on endocrine therapy or anti-estrogen therapy. So Mammoprint's a tool that we use. The PAM50 one, PAM50 is 58 genes that calculates a low, intermediate, or high risk. I don't know many doctors using this one, but it's another tool that we use, right? A genomic test, testing the tumor for risk of recurrence. And so this is kind of a busy slide, but bear with me, because what I want you to get from this is I want you to see, let me just move this out of the way up here. Okay, this is what I do as a surgeon, right? We're talking about the breast cancer treatment of the breast. So the goal, the primary treatment, I want to get rid of your tumor, and there's some tools I can use to sort of stratify whether or not we need to give you more treatment based on what's happening in this tumor. Right? So this is what the surgeon and the radiation oncologist do, and the medical oncologist is using these tumor-based prediction tools. Beyond the surgery, now we're getting into, well, how do I know, doctor, that there isn't cancer cells that went somewhere else? And how do I know that it's not going to lead to being somewhere else in my body? What are we using to check for this, the somewhere else? Are there circulating tumor cells, or as we call it, ctDNA, right? Are there little fragments of DNA in my bloodstream that are telling my body to do something? And there aren't a lot of great markers for this, but it's an area of very, very heavy research. And you can see here some of the blood-based markers. Some of your doctors might be ordering these tumor markers like CA15-3. They might be ordering CEA, which is very non-specific for breast. They may order CA29, right? ctDNA and circulating tumor cell tests. So these are where we're getting to. I know somebody put Signatera in the chat, right? We want to know, are we able to detect a minimal residual disease? Is there some fragment of cancer that's left over? Okay, so this is something very interesting, because now we can start to see, are we going to be able to develop some interventions? Do we need to give you chemotherapy based on this, right? Because there's cancer in your bloodstream. And then how do we get from here, this minimal residual disease, to actually metastatic disease? Does a high one of these truly mean one of these? And that is a question a lot of doctors are asking themselves. We're asking each other. And this connection here is not so solid. right? Because CA 15-3 is not so specific. CEA is highest in colon cancer even, right? CA 29-19 and CA 125, those tests are not so specific for breast cancer. And so it's very a confusing time for you because you're like, why can't there just be a blood test for this, doc? And some doctors are starting to look at some. So here we go. Signatera enters the chat, right? So Signatera, and this is taken directly from their website. I claim no credit for this slide, but the first time your doctor orders it, they need some tissue and they need a blood sample, and they're going to build out a signature here that they're going to start to look almost like a thumbprint. And they're going to look inside your blood to see if that signature or that thumbprint is there, right? So after they build the test, then every time you go to your doctor, they're going to draw some more blood. How often does this happen? Well, could be twice a year, could be every 3 months. It really varies, I think, depending on what that signature is doing. So here we are. They're saying repeated blood tests can help to see, are there some changes in the circulating tumor DNA? Are there little fragments in the bloodstream that can help your doctor understand if your cancer is shrinking, if it's growing, is it coming back? And so this is where we're now starting to get to, where there's some blood tests to sort of help with this. Right? And so how does it help? Well, in diagnosis, right? Let's say you got to get chemo beforehand. Can we draw your blood and can we look at those levels to see, is the chemotherapy actually working? As a surgeon, I use my clinical exam, right? After about the second round of chemo before surgery, that tumor is going to start to shrink. You're not going to feel it as much. I reorder imaging. So I have some tools that help me to measure how well a tumor is responding, right? After surgery. Now, are there people who have some disease that's left over? Should they get higher or more strong adjuvant or after surgery treatment than others? And then in the surveillance setting, are we looking at whether or not people are testing high for these levels? And if so, does it mean that their cancer's coming back? And if so, would they benefit from immunotherapy? So this timeline or this sort of pipeline is what we're hoping. The challenge is that what happens if you're after surgery and you're after chemo, right? And we're getting this blood test and here it goes and it goes down. What happens if it spikes again? Then you're thinking, oh gosh, my levels are up, right? My Signatera level is up. And we do, a mammogram, we do an ultrasound, we do an MRI, and we don't find anything. So now your insurance says, okay, well, you're not getting a PET scan. You only had stage 1 breast cancer. So now what do we do for the next 3 or 6 months? And if we get it again, 3 or 6 months later, and it's still kind of hovering here, what do we offer you? What do I say to you that this value hasn't gone down? It hasn't gone down, or it crept up a little bit, right? Maybe not up to here, but maybe it crept up to here. And so there's a lot of unanswered questions about how to incorporate these types of tests into clinical practice, because when we end up doing the workup and we don't find any cancer, but your numbers are up, what does it mean? And how do you, as the patient, live with the results? That is the question. Before we do any test, we need to anticipate, what are you going to do with these results? What am I going to do? If I order this test, what am I going to do with these results? And how do I justify and explain it to you? And
Dr.
so
Gary?
ask me anything.
Hi. Okay, yeah.
Yeah.
So it's interesting that you are talking about this because it was offered to me probably about
Mhm.
3 or 4 years in. And I was just kind of shocked. I was like, how are you going to get my cancer if you took it out? So that was
Right.
just scary. So I don't know if
Yeah.
you can, I was like, where is this cancer sitting if it's outside of my body to even run this test?
And the answer is we don't know. It's not outside your body, but certainly outside your breast, because my job as a surgeon is to get rid of the tumor and get clear margins, right? And you don't get to advance to radiation or anything else until I have clear margins, meaning the edges are clear, right? But these circulating cells, we don't know where they are. We don't know where they'll land. We don't know when they'll land. And so it's a tricky and a very nuanced conversation. And when you look at sort of who's using these the most, many doctors in academic centers are using them because they have tools to help refine, where do we search, right? How do we know whether it's going liver or brain or pancreas or lung? How do we begin to tease out the results of elevated levels of these? And there are lots of different ones of these on the market. Signatera is probably one of the ones that you hear of commercially the most, but many academic institutions have their own in-house, right? So they have their own version of this, and they're doing clinical trials to study that. And so maybe the best place for this might be in a clinical trial, perhaps. And again, this is editorializing. This is not Dr. Gary's viewpoint. I'm just saying this is how, we're starting to interpret this, but this might be the reason why your doctor isn't offering it. Because if you ask your medical oncologist, well, why aren't you doing this blood test that tells if my cancer's come back? They're going to say, because if the number's a little bit high, I have absolutely nothing to do to help diagnose that for you. It doesn't mean anything. There's no threshold yet by which we know that if it's this high, oh, it's got to be here. We just don't know yet. And so there's so many targets. And while it can be confusing, while it's daunting, while it is probably a very unsatisfying conversation that I'm having with you right now, this is important because this is teaching us that we are learning so much. And in the next several years, we're going to be able to look for signatures that help to unlock, proliferative signaling and evade growth suppressing. And we're going to look at how our immune systems are better fighting cancer cells, right? We can look for inflammation and polymorphic microbiomes, right? Our gut microbiome. We're going to talk about how our intestines contributes to our cancer risk recurrence. And so I think that this is something I hope that feels hopeful to you, because while it seems confusing now, confusion is the gateway to hope. Let me just say that, right? This is we're on the path and we're not looking back. And so just because your doctor doesn't offer this today doesn't mean that your doctor won't offer this in the future, because I believe that this in the next 2 to 5 years really will become much more standard of care as we're able to better refine and diagnose where cancer could be spreading. So the last thing I was asked to talk about, and this should be a separate topic altogether, is, well, what about precision wellness, right? We got precision medicine, precision oncology, and well, it's maybe not that precise, but we're getting better. So what about wellness? And this is when we talk about the things that you can control. So what is integrative oncology? Integrative oncology, we're talking about lifestyle modifications. It's a patient-centered, evidence-informed field of cancer care. It's not just the hoodoo, right? It's not just the thing that we kind of believe, but there isn't a science to it. But there is a science to how lifestyle modifications can influence your health, your quality of life, your clinical outcomes, how it can reduce your risk of recurrence. And so I like to couple this conversation, because there are things you cannot control. What's happening in your very cells and in your genome, what happened in your breast, what happened in your body, you cannot control. But the things that you can control, I call the 3 M's. Your meals, your movement, your mindset, right? These are things that you can control, and they actually do influence your risk of recurrence. It's not all just sort of, theoretical. So let's talk about the movement, right? How does exercise lower cancer risk? Well, first, it decreases the biologically available hormones, right? It's going to, and that decreased lifetime exposure helps to decrease the risk of hormone-related cancers. So you got breast, uterine, ovarian, prostate, testicular cancer. And this was a slide that I used for all cancers, but decreasing hormones can certainly help to decrease the risk of hormone-related cancers. I liken it as estrogen as the gasoline that makes the car go, right? We can empty out the car, the gas tank, so that the car is less likely to go down the road again. Well, let's talk about foods, right? Directly and indirectly, foods can help fight cancer, right? So you got directly vitamins, minerals, phytochemicals have anti-cancer effects. And I'm happy to talk more about this when I finish the presentation. We can have just a chat about what types of foods, right? But indirectly, decreasing fat, right? Low calories, you got more fiber, right? You have nutrient dense foods that are going to fill up your plate and fill up your stomach, so that you're less likely to eat things that are, the poor choices of calories, right? And there's a science behind that too. So you want to add your cancer protective foods, those phytochemicals, eat your rainbow, subtract the foods that are going to increase the risk, the smoked and processed meats, right? Processed foods, extra glucose, right? Sugar in moderation, and certainly from our fruits, is not a bad thing, but excess and exogenous sugar is something you want to try to avoid, right? Calorie dense foods, right? You want to replace those. So the phytochemicals are the cancer fighters. They're naturally occurring. They look, they smell, they taste, they chew. Oh, you're going to be chewing that kale. Absolutely. Unless you really, really rub it with some lemon juice and get it nice and tender, that kale's going to be awful chewy for you. But these things help to fight. Oh gosh, I left out the slide that talks about all the different ways that they fight. But they can fight by increasing and inducing natural killer cells. They can fight by being a cofactor for reactions in the body, right? By increasing and decreasing, excuse me, decreasing the DNA breakdown and increasing DNA repair. So your foods can help you fight. Let's talk about movement. Okay, so exercise decreases endogenous insulin. Higher levels of insulin are linked to lots of cancers and recurrence, right? And so we have IGF high levels associated with cancer risk recurrence. So moving your body has a benefit, decreases the risk of recurrence. And here it is, right? So we looked at a couple studies, and this is for 2008 AACR, and I've got an updated one on the next slide. But when women move their bodies, they decrease their risk by 15 to 50%. So 4 times a week or more, right, during the reproductive years, postmenopausal women with higher rates of activity have lower incidence of, but it also decreases the risk of recurrence. So let's talk about mindset a little bit. VEGF, the vascular endothelial growth factor. Tumors need blood to grow. They need nutrition and oxygen. So what brings it there? Blood vessels. So there's a hormone, right? There's a growth factor that says grow toward this tumor. It's like a garden, right? Where you've got a weed growing, and the bigger that weed gets, it needs more energy, needs more fertilizer, right? So something's bringing those blood vessels there. And what we find that women who had ovarian cancer, right, who had higher levels of social well-being, who showed up for the chat on a Tuesday night with Living Beyond Breast Cancer, had lower levels of this endothelial growth factor, right? So by being not in isolation, by being around each other, right? By being in community, by sleeping, right? Insufficient sleep and circadian rhythm disruptions are associated with negative health outcomes. Well, we always kind of knew it, right? But here it is in black and white. You got to find a way. And I ask my patients, are you getting to sleep? Are you staying asleep? And we talk about what does that look like? Are you having trouble getting to sleep or having trouble staying asleep or both? And what are some natural ways to help you to increase and induce your sleep, but have a better, more restful sleep? Because your body needs it. And here's the science behind it, right? Negative health outcomes, you end up with loss of gene expression and changes in the regulation of our genes and our immune and our stress response. And when our bodies are under stress, we do not perform optimally. So how am I doing on time? Need to get ready to wrap this up. But what's really happening is more than molecular, right? This is a great model that I came across that talks about how to conceptualize the fear of cancer recurrence. All these things are at play. Vulnerability, right? We're having traumatic life events. We're caregiving or being cared for in ways that we never thought we would have to, right? Things we don't know, the lack of information, all of that feeds into a heightened fear of recurrence, right? Our changes in ourself, our changes in what's important, changes in planning for the future. All of this is at play. And so when a patient asks me questions about recurrence, the conversation that I have has a good bit of science. It's got a lot of stuff you can control, those 3 M's, your meals, your movement, your mindset. And it talks a bit about this because this fear interferes with everything. And so the next talk that you're going to hear, I believe it's going to be next week, and we'll put up the information for it, talks about this. How do we manage this? Because no matter what surgery a person does, I have patients who do a double mastectomy and they say, well, now we're not doing any more mammograms. How do I know nothing's there? When they did the double mastectomy, so there'd be no more mammograms, so they'd have peace of mind. Right? But the fear is real and you should validate it. And it's important that you understand how to manage the emotional responses around it because there's no blood test that fixes any of this. And that's something that I want you to really think about because everybody rushes to their doctor and you ask for the blood test and then we do it. And then the next headache, you're right back at square zero. And so you've got to manage your mindset as best as you can surrounding recurrence so that all these things can really work together. There are some recommendations as far as healthy lifestyle. These are all the different societies. Like we're getting hip to the game now. ASCO, American Cancer Society, the Society for Integrative Oncology. This is a good one. You should go to their website and you will see practice guidelines on the evidence-based use of integrative therapies during and after cancer, right? So these are the things that have some evidence that shows how we're able to use integrative therapies to decrease the risk of recurrence and also improve your mindset around those things. So I want you to know that there is an evidence, there is a guideline, and there's a rubric that doctors can follow. So if your doctor says, oh, I don't know about that, just get up and move your body, walk to your mailbox, walk around your neighborhood. If you want more information, these are great sites for you to go to so that you can understand the benefits of sort of an integrative approach to reducing your risk of recurrence. The last thing I'll say is, this is oh gosh, a self-promoting slide of my farm, where we talk about benefits of horticultural therapy. We have, hort therapy classes, and we have a place for people to practice their meals, their movement, their mindset. And these are the types of places, wherever you live in the country, you should seek out, find community, find ways to maximize the things that you can do to reduce your risk of recurrence, increase your peace of mind, and your overall sense of well-being, because I promise you that the science is catching up. It's catching up very quickly, and I'm going to stop sharing. And Ebony Joy, I want you to come on.
Dr. Gary, thank you so much for that informative presentation. It was really, really good to navigate the things that we need to know in terms of recurrence, because I myself live with it a lot. And I want informed decisions, but there's so many things that are happening. And so a lot of people are asking that question too, is how do we know, for example, if we get to the end of our treatment, so you get a 5-year hormonal treatment and then you're done, then what next?
Okay, so for hormonal treatment, I'm sorry, I don't know why my light looks all crazy like that. Do I look yellow to everybody? Ugh. All right, I can't control it. Okay, so for the 5 years, right? We used to think that it was just you take that estrogen blocking pill for 5 years, and then it helps give you benefit for up to really up to 15 plus years. Now there's an assay that we can do. There's a good clinical trial, and there are tests that we can do to determine the benefit of extended endocrine therapy. So not that anybody wants to be on that pill longer than they have to, but we're learning now that we can either de-escalate, right? And we can drop off and decrease your therapy at 3 years, or we can keep going at 7 and at 10 years if you're on that estrogen blocker. There are some assays or tests that we can do to see if adding something extra to it, like immunotherapy, would be helpful as well. So yes, there is a test for extended endocrine therapy. You can ask your doctor. Okay, I'm going to put in the chat extended endocrine therapy assays, right? Breast cancer index. Yeah, BCI is one of them. Exactly right. But there's some others too. So, and EndoPredictive, I think, was another one. So yes, you can ask your doctor, and that will help you. Now, what if you don't have a pill, an estrogen blocker to take, right? And so for those individuals who have triple negative breast cancer, we know now that there are higher risk and lower risk profiles of TNBC even, right? Even if you have early stage triple negative, you may have a higher risk of recurrence and or distant disease. And so yours is going to possibly be coupled with some of the immunotherapy now. And so if you have TNBC and you're just starting your journey, ask your doctor, how do I know that something like Kadcyla or Keytruda, I'm using the drug names, I'm not endorsing any drugs, but these are I don't want to use the drug, the generic names, because they're, palbociclib and things like that. It's hard to understand. But you can ask your doctor about whether or not other agents would be helpful, immunotherapy, in addition to chemotherapy for you. So we're getting to the point where we know now there's some combination things that we can do. What else?
Thank you. So, okay, so you mentioned some health things in terms of sleep and exercise, but these medicines, when you're thrust into medically induced menopause, or, they come with a lot of things. So you need to sleep, but the medicines make you not sleep, or the stress makes you not sleep. So people are asking, what can they do to help with sleep?
Okay, so this is Dr. Gary's recommendations. This is not an endorsement I'm not diagnosing or treating you as a person, but what I recommend to my patients. One, I recommend tart cherry juice, organic tart cherry juice, about 4 to 6 ounces, usually 4 ounces, about an hour or two before bedtime. I recommend a sleep hygiene regimen, meaning you start powering down your electronics at least an hour before bedtime, ideally 2 hours before bedtime. You start to create create an atmosphere and an expectation of rest, right? Ashwagandha is an herbal supplement that can be very helpful for sleep. Magnesium. I don't think we realize how magnesium deficient sometimes we are. And so magnesium, you have to be careful with the dosing, but no more than 400 milligrams about an hour or two before bedtime, because magnesium can, as you imagine, milk of magnesium or mag sulfate, those things can influence your bowels. Right. So there's some natural things you can do, melatonin for sure, as well. But you gotta sort of, and yep, somebody put medical THC, Charlotte's Web gummies. There's a good turmeric tea. So you gotta figure out what works for you. And I suspect that it will be more than one thing. So don't give up. You got to find the right combination of things. Be willing to try a couple different things and not give up, right? There are also frequencies that you can listen to that will help with sleep. Certain megahertz will help. And it's ambient noise, but it's it's worth a try, especially if you are wanting to avoid something pharmacologic. So use every resource. Use the Calm app, go on YouTube and find those frequencies and really just keep a journal. Keep a log of what you're doing so that way it will help to see what's working, what's not working.
So a lot of women or attendees are asking about, just how do we know if this information is accurate, if your oncotype score is accurate, if your treatment is accurate? What is the baseline for this to see what is it working?
So you can ask that very specific question to your doctor, and what they'll tell you is they may, if they have the time, walk you through some of the subsets of people in the trials, right? Because the one thing about Oncotype is that they have tried to fit this test to so many people in so many different populations that there probably are some people that fit your profile that have been in the trials, either the early one or in the later trials. And so I think that it's a good question to ask your doctor, and that you probably are not an outlier. But if you are an outlier, someone should be saying to you, you know what, this really wasn't, you weren't a part of these trials. And, if you're 17 years old, for example, my youngest patient I've seen has been 17 with breast cancer, right? There weren't any teenagers in those trials. Right. So that person's an outlier. And so how do you got to sort of ask your doctor that question, what confidence do you place in this and why? And where they may take you is they may take you to something called the NCCN guidelines, nccn.org, putting it in the chat. It is very, it's a lot. It's like a roadmap, but it is the guideline for what most of us do. And it's a way that you can know that we're not just picking something out of the hat, but that there are actually sort of rules to how and why this applies to you. So the guidelines are a great place for you to go so that you can feel more confident that what you're getting is the standard of care.
Thank you. And someone asked, can you use the Oncotype DX test 5 years or years after treatment? Or when can any of those, the MammaPrint or anything, is there a timeline to use those, or they can be used anywhere throughout treatment?
Ooh, so I think that's a great question, and I honestly don't know the answer to that because I generally don't order an Oncotype years and years later. But it can be, I know MammaPrint can be used several years later. And that's one of the trials that's going on right now is there's a trial looking at using MammaPrint to predict extended endocrine therapy. So yes, as long as we have some tissue that we can use, and we call it in the blocks, like the wax blocks, because what you may not know is that when a tumor is removed, it goes to the pathology lab where they put it in a block of wax, like the wax museum. And then they slice it up on a little deli slicer, like a deck of cards. And then all of those cards get saved. And so if there's still tissue left in somewhere in the deck, we can go back years later and we can do additional testing on it. And so the answer is that yes, we can go 5 years out and we can look at those things. And so you can ask that question at any time, and your doctor should be able to at least tell you what's available to you based on where you are in your journey.
Thank you.
Mhm.
And so some of the research, right, that's out there is very, I guess, specific to certain racial groups or age groups or weight groups. When doctors are providing these things. So like for me as a Black woman, when I found out I had breast cancer, I immediately was like, looked at, oh my gosh, all Black women are more likely to die from this, or 40% or higher risk. And I was like, so that increases the likelihood of me worrying about, is this treatment working, because the data that they're using didn't test anyone like me. And so the confidence in the treatment plans is kind of like, to me, I hope it works because we didn't test anyone like you, so we don't know. And I've heard that's a different conversation. So for participants out there, what could provide hope or more confidence in a system that has marginalized or left out or just
Yeah.
made it look bad?
Yeah.
There's not the more positive news.
I love that question. And the answer is you can't walk forward looking backwards, right? And so it's we use so much retrospective data to inform future things. And if you weren't included in that retrospective data, how can we ever make any good conclusions about your future? I put a link in the chat on MammaPrint that's being done there was a study that came out actually this year back in May that looked at the influence of race and ethnicity on the genomic assay and on prognosis. So we're starting to answer those questions. And it's valid to ask your doctor, how do I know this is relevant to me? How many, what was the breakdown of people? And I'll be honest with you, the trials were not required to give all of that demographic data. So your doctor may not even know how many Black women were in this trial, right? But you can sort of go down that rabbit hole. The answer is probably not that many. And so one of the things that we're doing to rectify this, because what can we do moving forward, right? Can't fix what we did, but we can, looking forward, we're doing more trials like real world data, real world evidence. You will see that more and more. How are people doing on these types of therapies that help us to inform, the people who weren't included? Because clinical trials in general used to look for the healthiest of the sick, so to speak, right? And so you'd be excluded if you had diabetes that was not controlled, or hypertension, or kidney disease, or if you hadn't had a first line therapy, or if you failed a first line and if you didn't get, like you got to check all the boxes to be in a clinical trial. And so I think that we're getting better about opening and widening that lens. And so even the drugs that we're using now, we're starting to go back and test them on different populations of folks to see. And again, that may not be a satisfactory answer, and it certainly isn't for me as a Black woman, because I think about what's happening in my Black body too, and like, well, how do we know? And the answer is we got to get involved. When we're at the table, we're not on the menu. We got to get involved in clinical trials.
Thank you.
Mhm.
Someone asked, so I think a lot of people have been talking about, okay, this treatment to prevent recurrence, but all the side effects that come with it. And so hot flashes, can you talk about, a couple of people are like, I need to sleep, but these hot
Yes.
flashes, literally like in my house right now, it's cold outside, but I have my AC at like 65.
Mm-hmm.
And I
Now,
freeze everyone that
listen,
comes in here.
personal summers are real, and it wasn't until I hit perimenopause that I was really truly able to appreciate what cancer patients are going through, especially those of you who are on anti-estrogen therapies. I call them personal summers because it makes it sound, just a little bit fancier than. But what can we do? So there are a couple things you can do. One, you've got to look at what things induce your hot flashes, right? So let's start with natural stuff. Caffeine, right? Caffeine can induce hot flashes. Spicy food can induce hot flashes. Alcohol intake can induce hot flashes. So those are three things that you could start to modify. Not saying you can't have spicy food, but just know this can raise your basal body temperature. There are herbal supplements that can help to decrease the risk of and sort of mitigate hot flashes. Bee pollen extract is one of them. And again, this is not intended to diagnose or treat, but there are things that you can research and that you might talk to your doctors and your team about. Bee pollen extract is one of them. Evening primrose oil, although talk to your doctor about any interactions with evening primrose oil, which is a capsule, not an oil. Mushrooms, all of the lion's mane, the turkey tail, the cordyceps can help with that. And the last one, there's something called Veoza, Veozah, I believe. Veoza is it's a blocker, and let me look up what it blocks really quickly. And because the way it works is a hormone free, right, option for hot flashes and night sweats. So it's something to talk to your doctor about, right? It's a neurokinin receptor antagonist, so the thing that makes you flame on like Elmo, it blocks that thing. So that's something you can definitely talk to your doctor about.
Thank you. And
Mm-hmm.
so you spoke about diet, and someone mentioned keto or sugar is, I know no medical advice, but what guidance could you give on diet?
Okay, hold on. Putting acupuncture, yes, for hot flashes, it can help. Um, Things so the diet that's been most widely studied and most recommended to reduce the risk of recurrence is in fact the Mediterranean diet, right? So Mediterranean diet is going to be high in vegetables. It's going to have your good fats from like fish, and you'll have some lean protein in there. You'll have some olive oil. You're avoiding a lot of dairy, avoiding a lot of high sugar. You'll have some bread, but mainly like whole foods, right? So a whole food diet, a Mediterranean diet reduces the risk of recurrence.
Thank you. And so
Mm-hmm.
I would be remiss to not talk about the mental health portion of recurrence. I know myself, I can speak for myself. I
Mm-hmm.
obsessively, because I wasn't sleeping, I would
Mm-hmm.
obsessively look at everything breast cancer and figure out ways and when did I cause this on myself?
Mm-hmm.
And trying to navigate that.
Yeah.
What could you speak to in terms of like the mental health portion of trying to be, and a lot of times when I got my treatment plan, no one talked about the mental health portion of it until much later. And one of the hospitals I went to provided um, counseling therapy while I was in active treatment, and I continued on. So the mental
Yeah.
thing that cancer does
Mm-hmm.
with this whole recurrence, because I'm like, I didn't know it was in me. Now I know. And what if it can come back? And so what could you share with us about that?
Yeah, I think the first thing is to give yourself a little bit of grace and some space so that you're not one judging your body, right? Because people feel like, oh, my body, my body betrayed me, for example. You know, this body got us through every single thing that it needed to get us through, the good, the bad, the day that we had today, and this body will get us through to tomorrow. And so we honor this body. We're going to give it a little bit of grace because it didn't try to kill you. It didn't try to destroy you. For a lot of people, it actually told you something was happening in there. And for some of us, not so much. We found it early enough that we didn't have any clues. But seeking out mental health support is important. Finding, psycho-oncologists or oncologists who or psychologists who specialize in oncology it's a growing field, but there are not enough of them. So you can look online for some resources. I would check with LBBC. I would do a quick Google search. I would check with your insurance carrier and see if there are any oncology dedicated psychologists and psychiatrists, using your support networks, right? But find a therapist. And there's no shame in it. You got to find somebody to talk to and get this stuff out of your head. You need to start blogging. You need to start writing. You need to start journaling. You need to start figuring out a way to get it out of your head. And that's one of the reasons that people don't sleep. I tell my patients to keep a nightstand, a little tablet by the bedside, little, just a little spiral or whatever, and jot down the list of things I will worry about tomorrow. Right? Whether you choose to worry about them and look at them tomorrow, whether you burn them, whether you flush them down the toilet, put them in your Bibles, if you're a spiritual person, whatever it is, you got to get it out of your head. And in doing so, I think that, the benefit of finding good mental health support and acknowledging and receiving that support reaps dividends, because the reality is that very little in this life is within our control. Very, very little. And cancer is such a reminder of that very thing. And I tell my spouses, I say, listen, you're going to take a left turn instead of a right turn going home, and she's going to jump down your throat. Like, why did you take a left? We always take a right, because it's because you want to micromanage everything because the one thing happened that you couldn't control. And so knowing that and giving yourself again some grace around that is really important.
Thank you. And so triple positive, where does that fit in all of this with the oncotype and all the different things? Is some of this relevant to people that are triple positive?
So triple positive, HER2 positive, MammaPrint does work for HER2 positive disease. So MammaPrint could. Let's see. I think though in general, if you are HER2 positive, your treatment is going to be HER2 directed. And somebody put a question in the chat about HER2, are there any good assays for HER2? And the answer is yes, there are. We are learning that HER2 is not just high or low anymore. And how did we find these hormone receptors? Well, what we did, remember science class where you had to look at the onion peel under the microscope, and you took the little slip of onion and you put it and put the dye, and you now put the dye and you're looking at the onion as a wall. the way we look at hormone receptors is that we take a piece of tumor, put it on a microscope slide, and we look through the lens, and then we put a dye down to see, does it light up for the estrogen receptor? And how many light up blue? And you get a percentage, right? Same thing for progesterone. Put the green dye down, how many cells light up green? And the HER2 was either you had it, it was high, or it was low. Now we know that HER2 has a spectrum, right? There's HER2 low, and there's HER2 high. It used to be you were HER2 positive or negative, excuse me. And now it's like you can be high, you could be low, you could have some expression. And so we're getting to the point now where we can give more HER2 targeted therapies as well. So for the person who's triple positive, you're going to get offered an anti-estrogen therapy, right? That 1-a-day pill is going to give you for, 15 years of protection for taking it for 5 to 7 years, maybe 10 years. It gives you up to 15 to 20 years protection, but you're also going to get a medicine that's very targeted to that HER2 receptor and that treats your whole body. So we're looking at combination therapies. We're looking at teasing out HER2 high, HER2 low, and figuring out, it's not just positive or negative anymore.
Thank you. And someone mentioned KI67. Can you explain it, and where can you find it?
Sure thing. So the Ki-67 or Ki-67 is what we call a proliferative index. It will be on your pathology report. If it is not, you could ask your doctor, what is my proliferation rate? And, how fast is this tumor growing? Because you get your grade. When you look at your report, it'll say invasive mammary carcinoma, ductal type, right? So it broke out of the milk duct, and then it'll say grade, whatever, grade 2, 3, and then it'll say, your hormone receptors. And at the bottom of that report, it may say your Ki-67 proliferation index is 5%. If it's 20%, that's high. Anything over 20% is a high proliferation rate. And it means that the cancer cells themselves have a higher rate of growth, and it's a marker for a more aggressive type of cancer. And it's one of those prognostic factors that we talked about. When you say, how likely is my cancer to recur? Or how likely am I to need chemotherapy? That Ki-67 weighs into that conversation.
I'm so glad you mentioned that, because I was diagnosed in 2019, and at my pathology report read to me, I just recently got it read to me, and I was like, okay, I don't remember anything that person said 5 years ago.
Right.
And so because of the stress and so I know what that is, because there's more I guess I'm more present in conversations. And I'm more educated from being in these talks and things like that. So I think I'm glad that you said that, because I constantly now talk to my practitioners. I message them in the middle of the night, hey, instead of me stressing about it, can you tell me what research you're using, why this is, and they will send me the article. Or one of my doctors, I was like, I'm really concerned about this. And they reached out to Mayo Clinic to see if it would fit for me. So it's an ongoing relationship that I'm continuing to build with my practitioners.
Yeah, absolutely. And I love that you said that. And one of the things that you should remember, because I see people are putting a lot of sort of pathology questions in the chat, your pathology from the core needle biopsy, from that initial biopsy, is different, can be different than your final pathology. So like your grade could change. You might be grade 3 at first, and it's relative to the sample that we took out, right? We only took a little piece. That's all they had to go on. And so when you get the whole picture, your final pathology from the actual surgical excision is what matters. So don't just go by the biopsy, make sure that you now take into account whatever that pathology is after the surgery, because somebody said, well, why did my such and such, why did my grade change? Or why did my proliferation rate change, right? It changed because they had more tissue to look at. And they were able to make some more decisions about your grade, your stage, your node positivity. All those things came after the initial diagnosis and the initial biopsy. So I'm loving in the chat here. We're talking about joint aches, and somebody mentioned acupuncture. It does help. Acupuncture helps. The rising tide really floats all boats there. And making sure that you have good topical agents, making sure you have good movement, right? This is, again, those 3 M's, right? The meals, movement, mindfulness are not just to reduce recurrence, but help you get through your therapies, right? It can help us with our nausea. It can help us with our joint aches. It can help us increase our bone density. So I think it's really important. And I love that everybody's sharing these, because there's so much that we don't know. But the last thing I'll say, and getting to your point again about the whole mindset thing, is that we don't realize the negativity that plays in the background, sometimes. And one of the best tips I give to my patients is we'll take a few minutes in the clinic and I'll say, okay, you know what? I need you to just be still and be silent and tell me what's playing in the background. What are the background thoughts? What's the background music that's playing right now? And it may be that you don't feel good about yourself. And you know what? Every time you walk past a mirror, you're judging yourself because of the weight that you gained during treatment. It may be, you know what, this cancer is going to come back. It may be whatever it is. Like, what's the soundtrack that's playing? Okay, and now let's actively do a mental visualization exercise. And I want you to go over to that record player. If you can remember record players, most of us are old enough here, thankfully, right? I want you to take that record off and I want you to smash it. And I want you to put a new record on the record player. What does it sound like? What's playing? What music is playing? Right? And recognizing that we have to disrupt that feedback loop that runs in the background, that track, that soundtrack of our lives. And when you can recognize that, you know what, I don't have good things playing right now. The soundtrack isn't a good one. You got to stop and you have to consciously interrupt that soundtrack in your life. So that way there can be something different playing that's more positive and more hopeful for you.
So we have time for one more question. Well, let's do two because a couple of people asked about alcohol. So what are your thoughts? What are oncologists' thoughts about consuming alcohol?
All right. So my thoughts are, I get it, you know, and everybody's got a thing, but alcohol increases the risk of recurrence and it increases the risk for just about every cancer. The shortest answer as to why is that alcohol gets converted to estrogen, you know, and this, the biochemistry of the rings and it cleaves and you cut off the this and the that. Next thing you know, you've got estrogen, but it is estrogenic in not the good way. And it increases your obesity. It increases your risk of recurrence. It does all bad things. And so the recommendation for cancer risk recurrence is that you would drink less than 3 drinks a week, really, ideally.
All right. And the final question, I'm kind of putting them all together, but if you have a treatment plan, but you have pre-existing issues that say if you take one estrogen thing, but it's going to cause you, you have a propensity to have a side effect from it, where can you go to get an option that works for you? If it's alternative treatment, if it's medical, who do you question about what's the best game plan forward for you?
Yeah, yeah. So the first thing you should know is that in general, there's usually more than one medication to reduce recurrence if you are ER positive. Triple negative, again, different story. But if you're hormone receptor positive, especially if you're postmenopausal, there are several medications that you can try. If you are premenopausal, they may offer you ovarian suppression, right? So now you're going to get Lupron injections or something, or you may end up getting a oophorectomy, and that puts you into menopause, and then there's more options for you. So if you don't like how you feel on one, right? It's like blood pressure pills. Try another one. Take a holiday, right? And see, are these side effects a result of whatever, or the pill, or is it a result of, you know, perimenopause, or is it a result of that new mattress I need to get, right? That hip's hurting for a different reason. And so you take a break and under the direction of your doctor, and you say, look, doc, these side effects, I can't. I'm going to have to switch to something else. Can I take 2 weeks off and then switch to da 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 da? Right? And so you have that conversation with your doctor. You take those couple weeks off, right? 2 weeks is okay. And that way you get it out of your system and you see, oh, you know what, that knee pain is from whatever I've been doing, right? Or that knee pain is from that estrogen pill. And now that that's gone, oh, my thumb does feel better. I'm able to do my needle point again, right? So you can see how you feel off of it. Then you switch to another one. So there's different ways for that to go. If you'd like to consider holistic things, many doctors don't know much about it. And so, you know, it's kind of like in medical school, if we didn't learn it, it doesn't exist. But there are doctors who subscribe to holistic practices who can give you some advice. And there are naturopathic doctors, especially integrative oncologists, that you could search for. And so you might start with the Society of Integrative Oncology. That link I put, remember that chart I put, right? I'm putting it in the chat. Society of Integrative Oncology, because these are practitioners who specialize in adjuncts to, not, they're complements to, not alternatives to. And that's the way you should think about this. It's not Burger King where you can have it your way and you can do this, but not this, but not this. We all work together in complement. And so if you are changing your regimen, you should talk to your doctors about those changes, and you should talk about why you should do those. What is the data and the evidence behind it? And who are the practitioners who can help you to do that safely? Because many of our, sort of conventional oncologists don't subscribe to these. And so you want to be very, very careful. Avoid the snake oil, avoid the folks who are, honestly, be very careful, because if they're making you choose between one or the other, that is, in my opinion, not the way to go. I think that you can have your CMOS and you can use your CMOS to help you detox from chemotherapy. Like, it can work together safely, and find doctors who subscribe to that, because we know this Western medicine works. We know it can be toxic, right? But if your body can heal itself naturally, then surely it can heal itself from the effects of surgery and radiation and all these things. And how can you boost and support your body to do those things should be your questions.
Thank you, Dr. Gary. Any final
Mhm.
thoughts?
My final thoughts are keep asking all these questions, keep pushing and challenging your doctors out of our comfort zones, because these are not comfortable conversations for us, right? These are the ones where we start getting antsy and shifting on one foot and one hand gets to the doorknob because we don't know all the answers. But you can ask the questions and you can start to say, Doc, what does the regimen look like for me? If I want to change my diet, or if I'm worried about recurrence, what's a comprehensive way that we can address that? How do I know? What do I check for at home? Because here today, I might feel okay, but in the middle of the night, how do I know that back pain isn't something? When is back pain, and when is it recurrence? What should I be looking out for? And ask those types of questions so that you can better understand, how do you source peace of mind? And above all, prioritize your peace, because cancer happens whether you have 2% body fat and drink alkaline water and exercise 7 days a week, or whether or not you smoked 2 packs a day for 20 years. Like, it happens to everybody, no matter what you do or don't do. So it's not anything to blame yourself about. It's things that you cannot control, and all you can do is move forward in as much empowerment as you can.
I really appreciate that. When I started this journey in 2019 and I got that call, I'm actually sitting in the place. Wait, see, I'm gonna cry. I'm sitting in the place where I got the call. And my kids were 5 and 6 years old. I just started kindergarten first. And I'm sitting here at the same
Mhm.
space 5 years later, speaking to you and hearing your story about your mother. And, those are trailblazers, I think, that have paved the way. And LBBC being able to fly out to Philly and all the sponsors, I can't thank enough because I tell you, it's a journey beyond journeys. And if I have to be vulnerable and cry as much as I have been doing, but if it saves one more person, um, and put someone else at the seat to have a better chance, I'm going to keep doing it. So thank you all for providing this platform.
I love that you
um,
said that, and that you're sitting right there in that same spot, because it really is a full circle moment, right? And this is an example to people who are watching, right? You don't know what your life is going to end up looking like after cancer. You really don't. But look at you sitting in the same seat you sat in, with a totally different message and a different mindset and a renewed sense of empowerment, because it didn't kill you, it didn't break you, it can't. Seriously, nothing can. You are amazing.